Thank you very much. I really appreciate everyone still stay in this room. I'm the first speaker today and will be the last speaker today. But I appreciate all the speaker, moderator, and also the attendee because you made this program good enough. So today I would like to go through the multiple dystrophin management of thyroid cancer. It may be a little bit very similar to the topic that I had this morning. Let me show you these cases. I need to change to So this is a very bulky mass invasion of the trachea and the larynx, and also invasion of the skin. So I don't know what would you thinking about how to manage the patient have a cancer just like this. But maybe we can make discussion about this case later. So far, for this kind of cancer, what treatment options do we still have? For example, surgical resection again. But just like thermal ablation, separate into a curative and palliative purpose. And anyway, it requires general anesthesia and have possibility very high to make complication. And of course, we can refer the cases for tachysurgery. But database show the best case for me that after the massive tachysurgery may lead to the fistula formation, even the aspiration pneumonia. And radiation is also because radiation majority for palliative and the effect is actually quite poor. And in the end, maybe we do nothing and let the patient go for hospice. In clinically, we are a physician, including endocrinologist and surgeon. We take care of our patient every day. We search in all kinds of the risk factors that can predict our patient's prognosis. But to be a thermal ablation, I think one of the most important issues is that the tumor burden. And from a lot of reference, we know that once the residual tumor is large, the outcome will not very good. So this is the same situation for the red eye. Patient have a larger residual tumor, the progression-free survival and disease-specific survival would not look very good. So what can we do for the local regional recurrent cancer? We can have active surveillance. I think most of the strategy is active surveillance. We can let a patient go for surgical resection, radioiodine therapy again, radiation, tachytherapy, alcohol injection, and IFA, of course. So most of the active surveillance, and once the patient or the doctor found patient recurrent, we would suggest that maybe you can do neck dissection or remove the lymph node metastasis and follow with and without radioiodine therapy. So the patient will go in this circle, surgical resection, radioiodine therapy, and active surveillance again. But actually after the third time of the radioiodine therapy, the effect would be decreased and would be not that good. So we call it a refractory thyroid cancer. So you have the only weapon is surgical resection. But to be a surgeon, I know your difficult part that repeat surgical resection is quite easy to make complication and very difficult to manage the clinical structure recurrent cancer. And so the guidelines suggest that for selected patients with unresectable and not good for the radioiodine therapy and also the progression disease, maybe we should thinking about refer our patient go for external radiation or systemic therapy. But anyway, these two kind of methods, the effect is not that good and also carry a lot of side effects. So the review also suggests that before we really go for systemic therapy, we should thinking about is there any lesion have the possibility to go for a localized treatment. So now we have local treatment, alcohol injection, and IFN or the microwave. This is the local image guide ablation. So just like Dr. Na said that we can separate our cancer into the curative purpose and palliative treatment. And majority is based on account on the burden of the tumor. Is that just limited the tumor burden with the ability to curative treatment, but if the tumor burden is very big, no matter it's inoperable primary cancer or recurrent cancer, maybe we're just thinking about palliative treatment. And also I mentioned this so many times that sometimes the factor is not just only come on the tumor, but also the capability of the team in the center, such as the multiple discipline, surgeon, radiology, endocrinology, nuclear medicine, and oncology cooperation together. And today, to be ACTA conference, we are talking the ability using ultrasound guide to the thermal operation. So let me show you one case. This is a 56-year-old female, tumor invasion the trachea and the esophagus. And we do hydrodissection and do complete operation for this cancer. During follow-up, you can see show complete disappear of the lesion. And this is another old female. Unfortunately, she had skin tumor invasion. So for the cases of Dr. Bei mentioned, I think the first idea coming to my mind is to refer to the surgeon because it's really easy to take it out. So we let a surgeon management these cases and take it out. But 6 months later, their new growing is not just like a previous that kind of small, but it becomes even bigger. So this time, patient hesitate. And then we, the patient, have a thermal operation. That's a after 3 months and 6 months, you can see almost a complete disappear of the cancer. So thermal operation can be alternative method for a repeated surgical resection. That's a movie that I also have 2 demonstrations on the Friday for you. One is very close to skin and the other is close to vessel. So usually we do hydrodissection just like this. We try to separate all the surrounding of the lymph node metastasis. It's better to be just look an island site. It means that the tumor is totally surrounded by detrous water. Once we have good hydrodissection, then we start the thermal operation. So you can see now I separate the lesion from the surrounding vessel. I would like to skip this movie. So far, a lot of guidelines already mentioned how to manage malignant cancer. You can see Korea, Taiwan, Europe, United States. So yeah, we can do thermal operation to the cancer. And also Dr. Bei and Korea team published this 10-year result. And it gives a lot of backup to using thermal operation to management the recurrent cancer. And this is also a very good paper published by a Korea team that just Dr. Bei mentioned. Ablation can make trachea adjacent tumor less scary and easy to treat because after thermal operation, it can have a fibrous tissue formation and protect the trachea. But it can be divided into different situations that from easy part, the left side, and to the most difficult part in the right side. So let me show you one case. This is a trachea lymph node, have a relatively acute angle to the trachea. And you can look at the ultrasound and also the CT demonstrate the acute angle, the relationship to the trachea. So it means that you have very high possibility to do hydrodissection to protect your trachea and nerve and do a complete ablation. The other situation is that we have the acute angle paratrachea lesion and also have right angle paratrachea lymph node metastasis compared to the CT scan. So with hydrodissection, you still can achieve a very good result with also improvement the thyroglobulin level to undetected level. And even worse is the cases just like this, direct invasion to the trachea. I believe that the cancer did not go into the trachea, but I think it's also a very difficult situation. Since the woman have already left side vocal cord palsy, and surgeon cannot do anything for this, and at the same time, she did not have a systemic metastasis. So we did make a discussion and decided to do some operation for the woman. And after some operation, the dramatic improvement of thyroglobulin level to about 20 to undetectable, and the PET scan showed disappear of the activity. So if the surgical resection is not available, we can apply a radiofrequency ablation to the practice for management of recurrent cancer, combined with and without radiation therapy. And even that radiation therapy did not work anymore, we still can make a balance between the thermal ablation and active surveillance. And next, I would like to mention some recurrent and advanced cancer. Theoretically, we will use a surgical resection, external beam radiation, and the TKI. And just like previous mentioned, that will form some fistula formation. And even worse is a mass tumor may lead to a very massive breeding of the tumor. So I always thinking about what the liver guy is doing now, and that a lot of weapon and a lot of combination. So what's new of the thyroid cancer in 2025? Let's look at the guideline. In the last version, they just touched a little bit about the target therapy, mentioned maybe for some BRAF mutation, and only limited a 7-gene panel for indeterminate signoid nodule. But until 2025, now it put the target therapy very clearly in the guideline and suggest that before the systemic therapy, it better have the whole genome survey to have a guide to management of the cancer. So you can see from compared to 2015, this year new guideline put the levatinib and the sorafenib as the first line therapy, and the second line such as a couple then tinib as the second line therapy. So let's go back that if we can do surgical resection, external radiation, and the TKI therapy, and we just let the patient go for combination therapy, it alone would be good, or maybe we still have some chance to combine some local treatments such as IFA, external radiation, embolization, and TKI. So that's the cases. I will show combination with thermal ablation and external radiation. This is a 42-year female. Let me show you the PET study, and you can also look at the CT scan. The tumor invasion of the tracheoesophageal grew and also encasement of the cardiac artery. And at the same time, you also know a lot of lymph node metastasis in the upper mediastin. So we agree with that very difficult situation for these cases. So we apply the first IFA. You can see after ablation, dramatic decrease the tumor size and also the increased enhancement. And we follow up with external radiation. And after combination of IFA and external radiation, very obvious decrease of the activity in PET study. And the patient is continue to accept the target therapy, but just as mentioned previously, target therapy is not work for every patient. You can see after my local treatment, we apply a lot of different kind of target therapy, even the first line, second line, but patient cannot intolerate and the disease keep continuing progression. So you can see even that the target therapy did not work to management of systemic disease, but the local treatment still can protect the airway. So let's just see what would happen in the future. So the local regional external radiation, by using this method, we can reduce the FOB and improve the quality of life. And from our series, they have a very good local regional control rate after 2 years follow-up. Then I would like to show you the combination with target therapy and the thermal ablation. That's our original cases. So I think you still have this case in your mind, so I jump to the next slide. So we applied 2 times of thermal ablation to this bogey mass The middle part is the first time thermal operation, and the right side is the second time thermal operation for these cases. Although that we agree there's still a lot of tumor cell in the neck, but I think we obviously improve the quality of life of the patient. And that's the follow-up combination after 2 times of IFA and also application of the target therapy. And how about advanced unresectable primary cancer? I show these cases in the morning. This is a 72-year-old female dementia. The patient would not like the patient have a surgical resection. So you can see the bulky mass, compression of the trachea, and the deviation of the trachea to left. So we apply embolization first. That's the first embolization, changes the CT scan, very obvious decrease of the tumor mass. Then we apply the thermal ablation to the patient again. And you can see we decrease the tumor more, only arrest a part of the activity in the PET scan. You can see compare 3 times the PET study from the very bulky huge mass. After embolization and after IVA, we take control of most of the tumor. And that's the ultrasound study before our second IVA. Just previously mentioned, we use the microvessel imaging to find out the still viable tumor and carry out the second time thermal operation. And in the end, the tumor is very small, and finally the patient and the family agreed to go for a thyroidectomy. And the pathology showed no residual tumor. And in these cases, this 64-year-old male embolization operation and thermal operation. So these are very interesting cases. They have 2 tumors. One is in the within the middle part of the thyroid, and the other one is in the upper part of the thyroid and invasion of the trachea. So you can look at the CT scan. This is the upper part tumor, very poor location of these cases. In the upper part, invasion of part of the trachea wall and also the esophagus. So the first idea for our team is apply some target therapy. But you can compare before and after. Even 6 months target therapy, it means the 2 courses of the target therapy, they did not really changes of the cancer. So that's the before and after in the middle part of the thyroid. And this is a superior part. A little bit decrease of activity, but still the main tumor over there. So we thinking about maybe we can consider using the embolization. That's a contrast medium injection from the superior thyroid artery, but it did not really fit into the inferior part, but only few of the superior part of thyroid. And even worse, it did not go into the tumor at all. And how about the inferior thyroid artery? You can see inferior thyroid artery here, supply most of the major thyroid gland, and also not much into the tumor. But anyway, we do embolization for both arteries. That's a post-TAE. You can see after the embolization, we kill most of the middle part of the thyroid and also dramatically decrease the tumor that we cannot touch in the part invasion of the trachea. So now the surgeon agreed that maybe the timing go for the thyroidectomy, so they undergo the total thyroidectomy. And after the surgical resection, of course, we follow with a radiation therapy, and at this moment we found some lymph node metastasis show active, maybe work by radiation therapy. You can see after the radiation therapy, the tumor did not change at all in the trachea invasion part. So at this time, since the patient already lost their voice, he had a vocal palsy. So we made discussion with the team and also the patient, thinking about to do operation for the patient again. But very difficult to identify the tumor because it's just behind the trachea. So we're using a fusion image with PET to identify the potential location of this region. And try to make it better, we also ingest a contrast medium, try to enhance the lesion. But unfortunately, not like we done in hepatoma, we did not see any enhancement in the pre-marketed region or the enhanced PET study. So anyway, very difficult to do these cases, so we use a CT guide with a PET and ultrasound fusion to do IFA for these cases. You can see after the ablation, most of the tumor, maybe 70% of the tumor have been abraded by thermal ablation. And during follow-up, you can see no enhancement of the lesion. And in the follow-up, a dramatic decrease of the thyroglobulin level. I think that would be the last cases. This is a 76 male with cancer, and we apply embolization thermal ablation to downstaging. Then the patient had the opportunity to go for operation. So you can see very difficult situation for this patient from the upper mediastinum with lymph node metastasis, and also a lot of tumor invasion of the trachea. And also the trachea esophageal groove. A patient have damage to the recurrent laryngeal nerve. So we apply embolization first. That's the post-embolization pad. Decrease of most activity of this tumor. So we think that maybe the timing for the radioiodine therapy. That's the PET study. You can see there are some lymph node. Even the cancer is the right side, but there are lymph node metastasis in the neck. And also have a lot of lung metastasis at the same time. And the thyroid scan show only right neck have lymph node. So it means that the left neck was not sensitive to radioiodine therapy. So we do a thermal ablation for the primary cancer again, that's a before and after, obvious decrease of the tumor mass. And we start trying to levatinib after the thermal ablation. So you can see after embolization, after IFA, and after levatinib, we obviously decrease the activity of tumor in right primary side. So now surgeon agree go for surgical resection. You can see the comparison between two timing before and after. Then the surgical resection. So I would like to conclude my talk. Now we know that we can have a lot of weapons with multiple discipline and combination therapy, including the target and the local treatment. But still, we need to optimize the combination therapy protocol because now most of the cases is experienced and just clinical training and make discussion with the patient and our team. So when the timing to approach what kind of intervention need to be optimized, and the sequential is also very important. And now we combine with the target therapy. Maybe in the future we can proceed more precision medicine integration for our patient. Thank you.
Thank you, Professor Lin, for your very interesting lecture. I think we have time to take one question.
Yeah.
Dr. Xi from Taipei. As an endocrine surgeon, I am charged to as chairperson as my multidisciplinary thyroid tumor board at my hospital. So I got a very kind of refer from the nuclear medicine doctor. It's not a multiple lymph node metastasis at the refractory from the radioactive iodine. My question is very simple. I have a multiple lymph node. How the number, the upper limit for the lymph node you were doing the radioiodine? Why I ask the question because I refer my patient to Dr. Huang Jialun. He said I get doing the 3 or 4. The patient got very painful, and so I want to know the upper limit. If a patient is a redo, it's a very risk for the complication, and I need to do Thank you.
Maybe later some expert can give me some suggestion. If you ask me, I would prefer embolization first if they really have a lot of course, you can go directly combine with tachytherapy at the same time. But I cannot tell you very clearly which one is better because in our own series, sometimes it's because of failure of tachytherapy, then refer to us. But sometimes it's that the oncologist is thinking about maybe we can apply local treatment first, followed with systemic therapy for other lung metastasis. But since that we know that in the posterior neck, there are nerves such as accessory nerve. So if they have a lot of different node over there, might be difficult to delineate or identify the accessory nerve. Would be make damage to that, the patient cannot elevate their shoulder. But by using embolization, we did not need to touch directly with the hip to make a damage, the possibility damage to the nerve. Embolization can provide some chance to reduce the tumor burden first, then follow with some location with a different section of IFA, maybe better. I don't know if there any other option. May give it to Dr. Su.
There's one question.
Yeah, we still have another 3 minutes. Please.
I'm Jung Kim. Thank you, Dr. Lin, for sharing us with us your wonderful challenges. I really appreciate. I think that your lecture inspired me. Thank you. My question, although I have several questions, but I will give you a very simple question. You probably have some experience about embolization for benign thyroid nodule and this kind of aggressive thyroid cancers. And is there any technical or is there any differences regarding the embolism material or any kind of embolization method between the benign thyroid nodule in this kind of aggressive thyroid cancer?
Okay, thanks for your good question. I have no idea about that. So far, we are using the same size of the particle. We know we can use a particle, we can use a gel foam, we can use coil, we can use glue. Maybe we can make discussion with the IR. But majority of the size of the particle, majority I'm using particle. Particle is too small. It will go to the purpose embolization. For example, go into the brain, that area we don't want to go. And for the major challenge for embolization for benign and malignant cancer is that there are more neovascularization will be found in cancer cases. For most of the benign, sometimes even if it's very big, intrathoracic goiter extension, but anyway the vessel is a normal vessel. The difficult part may be to cannulate a normal vessel because sometimes the goiter become very big, the angle of the vessel will become quite sharp. But for the malignant cancer, even more difficult is that there are so many small vessels. So when is the timing to start the procedure? It's also very important. Sometimes the case you may take 3 hours, 4 hours, just try to embolize some of the small vessels. So I cannot say embolization is a very good solution, but anyway, it help part of the cases and can majority decrease the main tumor, allow us to bridging to IFA because IFA, if the tumor mass is very big, very close to the critical structure, very challenging for us. So maybe shrinkage then first, follow with IFA.
I'm Chang from Taipei Regional General Hospital. Thank you for Professor Lin's wonderful talk. I have a question about if the recurrent tumor is big, will you try the ablation first, or will you try the target therapy first? And when the patient has taken the target therapy, will you stop temporarily the target therapy and then to do the before the ablation to prevent the ablation complication? Thank you.
Thank you. Very good question. I would depend on the voice function of the patient. If the voice function of the patient is lost, maybe the cases I'm thinking about, I can do some safe IVF procedure. I would do IVF first, followed with target therapy. But if the patient voice function is still preserved, I prefer go for target therapy alone. Maybe try 1 or 2 courses, because from the cases of Dr. Bei, sometimes the effect for target therapy is very, very good. So target therapy still got a chance to preserve the voice function of the patient, but intervention would sometimes make some complication.
Should we temporarily stop the target therapy?
Oh no, not a big problem. Yeah.
So any other questions? So actually, I think there's a lot of different experience from different